Welcome participants who are here on the dot of 2 p.m. Geneva time. We'll just wait one moment to allow a few more people to enter in. There were a few in the waiting room, so we won't be a moment and we'll begin very soon. For those who are already joining us, please feel free to open the chat and tell us who you are and where you're from, or where you're joining us from. Let's make a start. Hello, everybody, and welcome to today's WHO Special Initiative for Mental Health Learning webinar, where we're going to dive into the topic of data. My name is Alison, or Ali Schaefer, and I'm a mental health technical advisor at WHO headquarters based here in Geneva. For the past 5 years, I've been leading the implementation of WHO's Special Initiative for Mental Health, and I'm going to be your moderator today with support from some of our other WHO HQ teams during the Q&A session. So Lydia and Giovanni, please give us a wave, Lydia and Giovanni. Lydia and Giovanni are going to be working solidly in the background throughout the webinar, keeping an eye on your questions in the Q&A and sharing a few helpful links along the way wherever we can. For a quick note to you, today's webinar is being live interpreted into Spanish and into English when we hear from our Spanish-speaking guest, Lenildo from Paraguay. To access the interpretation, you can click on the More button, and there is an option there called Interpretations, or it's got the little global world icon, and that will help you switch between English and Spanish as we go through. Please post your questions in the Q&A so that we can monitor these as we go. And I'll explain a bit more how we're going to operate our Q&A throughout the session in just a moment. Many of you who are joining today have joined previous webinars and may already be familiar with the Special Initiative for Mental Health. We launched the Special Initiative in 2019 and began real implementation in 2020. And the goal of the initiative is to increase mental health services for 100 million more people. Different countries have joined at different times and each are focusing on their own priorities. And so far, we've been working in 10 countries, and Cambodia was our latest to join the Special Initiative this year. We have these Special Initiative learning webinars a few times a year, and it's a chance to bring all of you, our stakeholders, together to share what we're learning, to share our progress, and explore some of the common challenges we all experience in our work towards reforming mental health systems. When thinking about today's session, one really significant issue stood out to us, and that was the topic of data. It's been one of the special initiative's biggest hurdles and challenges, and we know it's a challenge for many mental health providers, for governments, and program implementers. Recently, WHO published its latest World Mental Health Atlas, and it confirmed something for us that many of us probably already suspect or we knew, and that is that we are falling very short on mental health data globally. Only about 44% of low-income countries use digital health records that include even a few mental health indicators. In the Special Initiative Program, we're often asked about what our impacts have been. And when people ask this, they ask it like it's a very straightforward question, as though measurement and monitoring of a program like this is simply quite straightforward. And the truth is, the reality is, it is nothing but simple. It is very far from simple. Over the past couple of years, special initiative countries have really started to feel the ripple effects of poor national level mental health data. The special initiative is a large-scale program, so manual data collection in all our areas of work has simply not been feasible. And the digital systems in the countries where we work have not also been supportive or able, don't have the capacity to include mental health and the things we'd like to ideally measure. Our special initiative countries are seeing that without data showing how many people need services means that governments are still not allocating adequate funding to mental health needs. And if the services that do exist aren't actually showing the benefits of care, mental health continues to get pushed further down the priority list, whether that's in policy funding or even in human rights. Next slide. So for today's webinar, we've titled this, What Gets Measured Gets Noticed. And right now, mental health isn't being measured enough. So it's something that's often overlooked in broader health systems. And today we're going to dive deeper into this issue. We're going to look at global mental health data trends and WHO's work on testing some mental health indicators for national health information systems. I'll share a little bit about what the special initiative is and isn't measuring in our countries. And we're going to hear from our special initiative countries in Paraguay and Bangladesh, who've been doing some important studies around service user outcomes from the work that we've been doing. I'm also thrilled to have with us one of our special initiative donors, which is from Grand Challenges Canada. Welcome, Abigail. And they're going to share some donor perspectives on data. And then we've saved the best to last. We're going to wrap up with the all-important service user perspective. And we welcome Maria Divina to help us provide input to that element. Now, normally our learning webinars run for 1 hour, but we knew that data was such a hot topic and it's pretty detailed. So we've extended today's session to 90 minutes. But to keep you all engaged, I hope, we're going to mix things up a little bit, and we're going to insert some facilitated Q&A after some of the key topics and key speakers. So please, let's hear from our speakers, but put your questions in the Q&A as you go. And then when we get to the Q&A sessions, we'll be able to try and ensure this is more of an interactive session throughout. So without further ado, let's get started. I'm pleased to introduce our first speaker, one of my good colleagues, Dr. Dan Chisholm. Dan is a mental health specialist here at WHO headquarters, and he recently led the publication of the 2024 Mental Health Atlas. Dan's working with the special initiative and non-special initiative countries to pilot some indicators for national health systems. Thank you for your time, Dan, and over to you.
Thanks a lot, Ali, and good morning, good afternoon, good evening to all. Great to be joining this session with you today, latest in a series of webinars on the Special Initiative for Mental Health. So my role is just to get the ball rolling and set the scene a bit and introduce this topic of data and measurement. So I think we can all quickly agree that data is important and information is important. Three reasons I've put here, of course, to inform and help planning, policy, service development is one aspect. And then, of course, the monitoring of those policies and services and activities. And through that, we have the sort of information feedback loop so that when you obtain information and evidence about what's working, what's not working so well, you can use that to make improvements to the things that we're doing. So those are three outstanding kind of reasons for focusing on good quality data collection and information. But also, as we know, we do, as Ali was just saying, we do face a big challenge in this area. I mean, historically, it's nothing new, but we really face serious deficits in the quality and the quantity of the data relating to different aspects of mental health. So I'll talk about those just in a second. And I want to just make this distinction between, if you like, periodic measurement, by which I mean things like epidemiological surveys, or indeed something like the Atlas, which is a global survey of where countries are at with respect to mental health services. Those are, of course, very helpful, but they're insufficient or inadequate as a mechanism to regularly monitor the needs of the local population or the impact of services. That brings us to more routine level of measurement, day-to-day measurement of what services people are using, what quality are those services, and what happens as a result of contact with services. So this is particularly weak in our area and something that we want to see improve. So I'll say a bit more about those, and if we can go to the next slide, please, Lydia. Just to give a quick sense of what the kind of different like domains of that I'm referring to, and in a sort of simplistic kind of model here, we have sort of everything from service needs, by which I mean like the indicators of the prevalence and incidence of different conditions, or information about the determinants, social and other determinants of mental health, and exposure to either risk factors or protective factors for mental health. And then we move to inputs, which are generally more easily measurable. Do you have a policy? Do you have human resources for mental health service provision? What's the provision or availability of essential psychotropic medications? Things like that. And then as a result of those policies and service inputs, we see in countries production of services. So that's where we try to measure the extent to which services are available, are being used, are good quality, but also important other implementation aspects, like are services accessible to people? Are they affordable? Issues like that. And then finally, we come to the service outcomes, dealing not only with things like symptoms or functioning or quality of life, or indeed fatal outcome measures like suicide, but also some of those other important outcomes for people, social, economic outcomes like employment. So you can see below the various sort of the differences in the type of data sources that are needed to answer those questions above about whether it's inputs or outputs. And it ranges from these periodic assessments like epidemiological surveys, or if you don't have those, you might be able to rely on recent updates of things like the global burden of disease, and then through to administrative data. And then on the right-hand side, you see where we really need either rely on routine measures of service users' experiences or outcome or contact with services to be able to see how well they did, or rely on research data for estimating expected service outcomes for people. Next slide, please. So just talk about a couple of the periodic updates of data. There's two reports that were released by WHO at the beginning of September. This was one of them. And in 2022, there was something called the World Mental Health Report. And this is effectively an update of a particular chapter, which had all of the data around, as it says here on the left, epidemiology, the burden of disease, dealing with the economic consequences, what are the latest estimates on that, and then looking at a series of gaps in terms of services and resources, much of which draws on the second report, which is the latest mental health atlas. So please take a look at this. There are some latest updates, for example, indicating that according to the latest global burden of disease estimates, more than 1 billion people across the world have a mental health condition, mental disorder. This latest prevalence estimates, and you'll find in there information about suicide, burden of disease, and so on. Much of the, as I say, the last part of this is dealt with by the second report. If I can go to that, please, Lydia, the Mental Health Atlas, which was first undertaken back in actually 2001. So this is the latest update of that since 2020. So you can see the type of topics that are addressed through this report. And of course, this is all being summarized and aggregated up to the level, not global, but also WHO regions, but also World Bank countries at different levels of income. So lower or middle income countries, high income countries, making those comparisons. And it looks at many of those service inputs and to an extent outputs that I was showing before, looking at the extent to which programs have been implemented or policies that are in line with human rights international instruments, extent of public financing for mental health or financial protection as well. So a whole range of different topics. So again, take a look at that. We're in the process of generating country-specific profiles, which of course are all going into this global report, and those will be made available through our website in the coming weeks. Next slide, please. This is an example of how data is being used to monitor, in this case, a global action plan. This is the WHO targets that we have, and using this data source to track progress and improvement and compare how we're doing compared to earlier time points. And you can see how there's a mixture of improvement in some areas, like in policies or plans that are in line with human rights. And then for other areas, we see actually less reporting or less achievement than before. So this would be the same for a regional or a country-specific plan, using information to hold governments or people, stakeholders to account for the commitments and that they have made in these areas. Let me finish by moving to the period, the more routine. Next slide, please, Lydia.
1 minute, Dan.
Yeah, that's perfect. This is my last slide. So this is coming to the routine health information systems and what we can do to improve the quality and flow of this kind of information. So we've recently been identifying a range of potential indicators that could usefully summarize activity in this domain at the level of health facilities. We're now ready to go to specific countries and test and validate those, and then we'll, on the basis of that, be able to produce some guidance for countries or program managers in countries to adapt and use this themselves. So this is the plan we have. Maybe I have got one more slide. It's to show a glimpse of the indicators, Lydia, of the kind of data that we're talking about, and these are still being finalized, giving a sneak preview of the kind of issues. And many of these are actually already being collected through the countries participating in the Special Initiative for Mental Health. So that's my segue back to you, Ali, to tell us more about that part of the information.
Thank you.
Over. Thank you.
Thank you so much, Dan. It's a bit to take in, isn't it? But I think the key message is that we're starting to see some improvements and some recognition that that mental health needs to be measured, and there's some very slow progress that's going on. But at the end of the day, there's still a massive deficit of data that's required. And while some of these periodic assessments, like epidemiological studies or individual studies, are helping fill some of those gaps, what we really need to be paying attention to is this everyday routine kind of data that needs to sit in health information systems. So we've got a few moments now to take a few questions. I haven't actually monitored the Q&A. I wondered if maybe Lydia or Giovanni could jump in and give us a summary of any of the comments or questions.
I can do that, Ali.
Thank you,
We
Giovanni.
have one question, actually two now, but the first question from the Q&A is, how can we as policymakers and academics based in these contexts help the WHO Mental Health Special Initiative, given how we've lost a lot of USAID funding, particularly in Pakistan, Afghanistan, etc.?
Okay. I'm not sure if that's a question for me or for Dan. So I suppose one of the most common questions we get asked in the special initiative is, can my country join the special initiative? And it's not a closed group. The considerations that we make in the work that we do in the countries for special initiative is that we have a predictable amount of funding that goes into a country for a period of 3 to 5 years. So we're looking at systems reform and things that take often extended periods of time. So, and health information systems is something that requires continuous work. Now, something that everyone could be doing in their own countries is actually promoting the need for additional data, and not just individual projects, but actual integration and improved health information systems. And WHO is available to speak to countries who are specifically interested in addressing the health information system needs in their countries. But we do kind of, at this point, I think this work that you're doing, Dan, is on the indicators, is something that's a little more systematic, and there's a few considerations that might be needed for countries who are interested to participate. Do you want to tell us a bit more about that, Dan?
Yeah, and this is, I guess, in relation partly to also the second of the questions, which is a great presentation. Can you share the full list of indicators? So we're, as I said, you know, it's a multi-phase project, and we're at sort of finishing phase one, which is identifying through expert consultation a set of potential indicators. So this is not the final set of indicators because they haven't been tested and validated, but we already have some experience in special initiative and other countries, but we need to do more testing and validation of these, particularly when it comes to some of those service quality measures, actually measuring in routine practice the level of, for example, symptoms or functioning. That's obviously a big challenge for many countries. Yeah. So we want to ascertain whether it's feasible, if it's useful. So this is very much a work in progress for now, and just sharing with you this is the plan that we have over the next several months to go out and test this a bit more. Regarding, there was a question about the publications, so they are embedded. So if you go to the presentation, which we'll share, they are linked, but I'll put them also in the chat over the next in the next couple of minutes.
Excellent. Is there maybe another question that we can address at this point?
Yes, there are two questions related to Dan's presentation. One is, are the ICD-10 CM codes you're focusing on for M&S conditions F01 to F99? This is important to report the correct morbidity indicators. And then I'm curious about the data tools organizations are using. Is there a single data tool or technology that the WHO or any other global public health organization considers essential?
Yeah. Okay. So for the first question around the ICD, so we do plan to cover not just mental health conditions here, but also some neurological and substance use conditions, which basically means that we are considering the full ICD-10 Chapter 5. So as mentioned there. But again, we will have to see how well these different indicators perform in and across these different ICD areas, including the ones I've just mentioned. Regarding data tools, the main objective we actually have is to develop a module that can be integrated into DHIS2, which is a leading tool used in a lot in Africa particularly, but also in Asia and Latin American and other parts of the world. So we will produce some guidance which can be used in a range of data systems and technologies. But one explicit intent is indeed to make sure we have something that countries that are already using DHIS2 can then use and develop or incorporate a mental health module.
Great. Okay, I can see more questions are coming in, and this is awesome. I want to move on, but I'm going to ask Lydia and Giovanni to maybe take note of the questions related to this topic, because we're going to have an open Q&A session towards the end of the webinar as well. So hopefully we'll have time to reach more of your questions towards the end. I do want to move on to the next three features, which is specific to the Special Initiative for Mental Health. So I'm actually going to present to you a little bit about what we've been measuring and how we've been tracking programmatic progress across the Special Initiative countries. So what I'd like to do is I'd like us to look, I'd like you to just look at this summary of some of the achievements that the Special Initiative has made over the last 5 years. This has not happened overnight. And it's estimated so far that we've increased or expanded access to nearly 90 million more people. And from what we've tracked, at least 1.5 million children and adults have received mental health treatment and support for the first time. Now, we say at least because this figure is actually only based on partial data. It's not a coverage indicator. Next slide. The Special Initiative Monitoring Framework is using a set of common indicators across all of our countries, while at the same time each country is tracking some of its own unique priorities that's specific to that country. So that might be additional indicators such as policy reforms, training, or deinstitutionalisation targets. We began assessing Special Initiative progress with 6 indicators. And this year we added an indicator on supervision. And we also added for the first time a separation of anxiety and suicide risk self-harm in the types of services that people are using. Access to services has been relatively straightforward to measure, and that's because it's based on the number of facilities that are serving a particular population. So this doesn't necessarily mean that everybody knows about or uses those services. For treatment, instead of true coverage, we're relying on the number of new cases in a few selected Special Initiative sites in each country. You see, if we were to calculate coverage, a real coverage indicator, we would actually need pretty solid baseline epidemiological data on mental health conditions. And for most of our special initiative countries, that data simply doesn't exist. So it's very difficult for us to correctly and accurately assess a true coverage figure. And this is why when we report from the previous slide, don't have to go back to it, but this is why we say at least 1.5 million new cases. We acknowledge that that's probably actually an underestimation. Some of the other indicators have been a bit easier to track because they're easier to track through sort of manual documentation. Things like number of people trained, the number of organisations we're engaging with, quality rights, which is largely e-training based, has been particularly easy to track as well. Supervision, I just want to say, has been an interesting indicator to add because this is something that's prompted more countries to actually ensure supervision is being provided. So now the countries have to report on supervision as an indicator. It's giving us a bit more of an assurance that supervision is actually happening, particularly for the non-professionally trained workers. The next slide. Now, that gives you an indication of the scope of the special initiative, some of those numbers. And given the scope of it, we can't measure everything. Ideally, we'd assess true access, we'd assess comorbidities, we'd look at service user outcomes, we'd look at impacts of training, national level coverage. But all of this would require significant time and funding. And the special initiative has instead directed its efforts more towards implementation and scale up, and only reserving a smaller amount for some of the data requirements that some people are seeking and some people would wish. Gaps in the country health information systems is also something that's making our data collection quite challenging. Next slide. Some countries in special initiative are still not even disaggregating data by gender or by age. So when people say, can you tell us, what's the gender split in such a country? Some countries can't even report that. And some countries can't report even adults versus children, let alone, 0 to 5, 6 to 11, all of those really important developmental milestones of child age groups and older person age groups as well. Some regions are still relying very much on manual data collection, and mental health is often recorded as a single condition. So when a health worker sees someone for a mental health condition, they tick the mental health box, and perhaps that's all that they do. So that doesn't also give us much specificity around some of the morbidities that people are being treated for. At this point, none of our special initiative countries have that daily, routine, systematic data collection on service user progress. And so there's a lot that we would love to be reporting on, and there's a lot that people think, oh, wouldn't it be good to know this? But I think we need to understand that we're actually asking a lot from a program of this level and scope. In the next slide. I included this slide because I wanted to emphasize that programming and getting scale up and getting access to services is really important. The implementation side is really, really important. And we do need to always think about striking a balance. It brings a bit of an ethical dilemma to us as well. I think it's essential that we have to remember that we can't fall too far down a trap where the demand for perfect data could actually result in less access to care. So if we spend so much time trying to get perfect data, we're using important time and resources that could take away from the true treatments that could be occurring. At the same time, we still need to know some information. And so perhaps this is also about us embracing some imperfect data or looking at data a little bit differently, or undertaking some supplementary data. So in the special initiative, one of the biggest questions that we are also asked is this actually working? Is this making a difference to service users? And the service users that we're treating is largely through some of those MH gap-based services that are integrated into primary health care. Next slide. Over the past year, 5 of our special initiative countries have run a really simplified outcome study inspired by the concept of sentinel surveillance. This has not been true sentinel surveillance. It's just kind of been an inspiration point for how we designed the study. We looked at the WHO Disability Assessment Questionnaire and tracked the progress of service users in selected sites in 5 countries. And what has been amazing to us is that the results have been strikingly different in each country. Some countries have really struggled with follow-up. One country reported unusually high rates of psychosis, and that may have been because of the types and the way services were provided. Another country faced major challenges even managing basic data collection. So I'm going to introduce now, first our Paraguay speaker and later our Bangladesh speaker, and they're going to talk to us a little bit about data that they learned from this simplified study in their countries. So even though we had similar methods in both countries, you'll actually start to realise that the results differ enormously and very, very widely. So I am really pleased now to introduce you to Dr. Lenildo Mora, who we've had the pleasure of working with in the Special Initiative for many years now. He is our WHO Paraguay Office NCDs and mental health lead, and he's been instrumental actually in Paraguay helping to shift mental health from services of centralised care in 1 or 2 psychiatric hospitals through to a decentralized community-based approach. So Lenildo will be presenting in Spanish. So if you'd like to hear the English translation, please remember to go to the More button and switch over for your translation. Over to you, Lenildo. Thank you for being with us.
Bom dia a todos e todas. Primeiramente, agradecer a invitação para estar em esse webinar, né? Agradecer em especial toda a equipe da OMS e também do escritório regional que me apoia muitíssimo em esse trabalho acá em Paraguai. La próxima diapositiva. Next. Bueno. Hablando um pouco do contexto de Paraguai, né? Paraguai é um país que tem cerca de 7 milhões de pessoas, né? Tem somente um hospital psiquiátrico e a princípio da iniciativa tinha 194 pacientes. Hoje, né, ele conta com 74 pacientes, né? É um país que teve muitas demandas, né, por transgressões dos direitos humanos e também demandas legais, né? O processo de desinstitucionalização era um processo muito árduo, muito difícil, né? Mas com a iniciativa está avançando, né? Existe uma fragmentação entre os serviços de saúde. Pero la buena noticia es que en 2022, né, el país lançou uma nova lei de saúde mental. E com base nesta nova lei, né, nós outros começamos, por exemplo, em 2023, né, trabalhar a sua regulamentação. Hoje o país está regulamentado nessa lei. Ele tem uma política, ele tem plano e tem protocolo. Trabalhamos muitíssimo nesses últimos 2 anos para fortalecer a governança. Próximo. Next. Además da governança, então, começamos a trabalhar com o fortalecimento de recursos humanos, né? E o país elegeu como estratégia para fortalecer saúde mental em el país o programa de MH-GAP. E aí o programa integral, né? Começando com a guia MH-GAP comunitário e também MH-GAP humanitário. Essa é uma diapositiva só para mostrar um pouco dos avanços que o país tienen, né? Começamos em 2020 e agora em 2025 já temos uma capacidade instalada. Todos os departamentos desse país que antes não tinha, há um psicólogo e um psiquiatra capacitado que são capacitadores em la guia MAT-GAP para o primeiro nível de atenção. Temos várias pessoas capacitadas em MAT-GAP comunitário e também esse ano implementamos um modelo de MAT-GAP pediátrico, onde também temos pessoas capacitadas para replicar. Nossa estratégia de trabalho junto com o governo foi justamente fortalecer as capacidades locais para fortalecer, né, o país e o país ter seus próprios profissionais para fortalecer essa rede de saúde mental que estamos implementando. Hoje, em números, temos aí mais de 200 agentes comunitários capacitados em MAT-GAP comunitário, mais de 100 profissionais especialistas que podem replicar para o primeiro nível e agora nosso grande desafio, né, é fortalecer também MAT-GAP humanitário, as emergências, porque esse é um país que tem muitíssimos desastres naturais, inundações, sequias, né, e necessitamos fortalecer. E aí, por isso, queremos, como o país optou, implementar todo o programa MAT-GAP. A próxima. E claro, como para nós outros foi muito importante a implementação da vigilância sentinela. Necessitávamos de evidência, né, para fortalecer a atenção primária. E escorremos um município muito diverso, um município que tinha muitos problemas sociais, econômicos, de uso de substâncias, e em esse município escorremos 16 USF que foram capacitados, todos esses médicos e licenciados em enfermeria dessas 16 USF, Unidade de Saúde da Família, foram capacitados para implementar esta vigilância sentinela, que para nós outros foi um êxito, né? Agora eu vou mostrar um pouco dos resultados, não vou detalhar, mas para que você sepa o resultado que tivemos com esta implementação dessa vigilância sentinela. Next. Acá em esse slide a gente vê um pouco da característica demográfica dos participantes por rango etário e também por sexo. Claro que a gente tem uma proporção maior de mulheres, porque em todas as investigações a gente sabe que há uma maior participação delas mulheres, e também quando se trata de saúde mental a gente sabe que ainda há um estigma entre os homens para acudir serviços de saúde mental. E em el lado esquerdo temos aí as principais diagnósticos que encontramos em esse processo, que foi ansiedade, depressão, né, uso de substâncias, epilepsia, entre outros. Próximo. Next. E essa diapositiva, assim, só para consolidar as intervenções que utilizamos durante a implementação de la vigilância sentinela, que foi justamente intervenções psicossociais, intervenções psicológicas, uso de medicações e também os tipos de tratamento. Next. E essa é a diapositiva que para nós outros é a mais importante e essa que nós outros, né, vamos utilizar e que vai nos fortalecer, que mostrou muito claramente, usando uma análise de Cuscoal, que durante as 3 visitas a gente pôde observar que há uma redução das discapacidades em todos os grupos, né? E isto é o que fortalece e o que vai nos dar evidência que a implementação da guia MHGAP em la atenção primária, ela funciona, ela é eficaz, mas acá cabe recalcar que, barro a essa a estrutura que o país está organizando, é que, además de termos os profissionais de atenção primária, temos um psiquiatra e um psicólogo que hace a supervisão, né? A implementação dessa vigilância foi importante para consolidar isso, para demonstrar para os gestores nacionais, municipais e departamentais que necessita ter um psiquiatra e um psicólogo para dar retaguarda a esses profissionais que estão solucionando e atendendo essas pessoas em las USF. Next.
1 minute, Lenildo.
Sim. Então, baseado nisso, tivemos uma série de recomendações que vamos implementar, né, em el país, né, e uma delas é justamente expandir, né, e melhorar essa atenção, né, ter mais foco em algumas populações que foram subrepresentadas em esta sentinela, que é, por exemplo, melhorar os horários de atenções, né, a ser mais campanha para reduzir o estigma, né, continuar com com as capacitações, a ser monitoreio e avaliação, né, desses profissionais que atuam em essas USF e também expandir esse sistema de vigilância para outros departamentos com vista a implementar em todo o país. Next. E por fim, né, seguir expandindo o programa MHGAP, fortalecer, né, fortalecer o sistema de informação e os indicadores. Essa é uma coisa que está pendente no país, mas estamos trabalhando nisso, né, melhorar a atenção em emergência, né, melhorar a articulação entre os sistemas de saúde, seguir com a desinstitucionalização e agora estamos implementando o CPQ, que vai ser uma outra evidência para a gente apoiar o país nesse processo de desinstitucionalização. E por fim, next, dizer que o país já tem uma guia para a implementação e também o país, junto com nós outros, estamos implementando um sistema de informação, uma app, que vai ajudar os psiquiatras e os profissionais de atenção primária para ser seguimento e avaliação em la atenção primária. Next. Por fim, a boa notícia é que o país, em 2020 e 2026, vai inaugurar 2 centros de saúde mental comunitária, e por isso estamos trabalhando muito em saúde mental comunitária, e também está ampliando, em esse processo de desinstitucionalização, a criação de salas de curta instância em hospitais de todo o país, né, mais específico em 4, para justamente atender as emergências psiquiátricas, para que essas pessoas não tenham que vir ao hospital psiquiátrico do país, que aí as distâncias cá são enormes. Graças, né, por a oportunidade de estar aberto e mais uma vez agradecer aos ustedes por todo o apoio que estão recebendo, tanto a nível de nossa oficina também, e aí eu digo a nível do governo, que tem todo o apoio. E hoje, só para acrescentar, hoje saúde mental está transversal. Hoje o ministro, os ministros, o presidente, em todo se habla em saúde mental. Por último, dizer que, por exemplo, o plano de desenvolvimento 2050 para o país uma das coisas que mais foi fortalecido em esse plano é justamente fortalecer saúde mental. Muitíssimas graças.
Lenildo, thank you so much. You have gone over time, but I wanted to let you go because I know how passionate you are about the work that's been going on in Paraguay. And I want to say that the special initiative will be phasing out of Paraguay over the coming years. And that's because of the strength of the work that's been done in the country. So the work has been, the mental health system has been transformed and is moving towards actual government and local ownership, and it's been absolutely remarkable. But I loved what you said, that we're getting positive user outcomes from the work that's been done. MHGAP is demonstrating that it has its benefits, but it's not a panacea. It's not everything for everyone, and we still have to deal with common issues like stigma. The professionals are still needed, even in a task shifting approach, and surveillance is still desperately needed. So thank you so much for sharing that real world scenario in Paraguay. So just before we go into a few questions aimed towards Paraguay and Bangladesh, I'd like to invite Bangladesh to present next. I invite our mental health focal point there, Ishakul Kabir, who's been with Bangladesh for a couple of years, and he's going to present the surveillance and service user outcomes data from Bangladesh. Over to you, Ishakul. Thank you.
Thank you, Dr. Allison. So, good morning, good afternoon, and good evening, everyone. I am Dr. Ishakul Kabir. I'm a program officer for NCD and Mental Health at WHO Country Office, Bangladesh. It's a privilege to share some crucial insight from Bangladesh, how Bangladesh is translating a global strategy into the local action for mental health. So for years, global community has championed the integration of mental health into primary care. In Bangladesh, we made substantial progress under WHO Special Initiative for Mental Health and by implementing the MHGAP. We have started the MHGAP in 2019. However, in the last few years, we have trained more than 1,000 healthcare providers, mostly doctors and nurses, on the MHGAP. Though progress is not just about rolling out the tool, it's about the quality and the impact it has on the lives of the service users. To better understand this, we conducted a structured study across 3 primary healthcare facilities in Bangladesh. Today, I will present the findings on to monitor the MHGAP-based service delivery and the outcomes in the routine settings in Bangladesh. Next slide, please. MHGAP program is launched by WHO, and we have adopted MHGAP intervention guide, that is MHGAP Bangladesh version 2021. That is a little culturally adapted as our country context. So in our special initiative, we are expanding the mental health services in the district and Upazila level. Currently, we are working on the 10th district, and our primary focus is to train the primary healthcare physicians and frontline workers in the MHGAP. Also to strengthening the referral linkage between the primary, secondary, and specialist care. We have 2 specialist hospital and institute in Bangladesh, consisting of 900 beds for over 170 million of population in Bangladesh. So in our study, we aimed at firstly, we wanted to assess the functioning outcomes. Sorry, next slide, please. So we wanted to assess the functioning outcomes of the people who receive MHGAP services to see their ability to carry out daily activities and roles may have improved after receiving care. Secondly, we aimed to explore how MHGAP trained healthcare providers are applying that tool, both for making diagnosis and guiding appropriate treatment in routine settings. And thirdly, we wanted to learn from the implementation experiences to understand what worked, what didn't work in the field, what challenges were faced, and how we can improve the MHGAP delivery going forward. Next slide, please. So we collected data from the March to July 2025. Sorry, next slide, please. there was 352 visits recorded from 298 participants during the period, and average follow-up duration was 3.6 days, with a range from 1 to 70 days, showing that some participants had multiple visits during the study period. The average age of the participants were 33, with female participants averaging 31 years and male participant around 38. Next slide, please. About the participant, it's interesting findings that most of the participants were female, 22, and male were 76. The majority of the participants presented with the common mental health disorders, notably anxiety 58.7% and depression 33.2%. So it is almost every 80% of the baseline visits. A small proportion was for self-harm, suicide, only 17 cases, and psychosis 3 cases, disorder due to substance use 1, and epilepsy 1. The first time MNS visits are more common among younger and middle-aged adults. Next slide, please. So what are the findings? Overall, the most frequently prescribed, we did find that were antidepressant, anti-anxiety drugs, and benzodiazepine. They were commonly used for the people presenting with anxiety and depression, which make up the majority of the service users. In few cases, some of the drugs, medicines were also used, like thiamine, for the participants presenting with self-harm or suicide behavior. But main treatments include benzodiazepine, antidepressant, or anti-anxiety medication. However, in some cases, no medication was prescribed. For epilepsy, prescriptions mainly involved antidepressant or anti-anxiety medication, and for psychosis, we also observed that use of benzodiazepines and antidepressants. So no pharmacological treatment for disorder due to substance use. Next slide, please. For the psychosocial intervention, that includes the following components, like psychoeducation, reducing stress, and strengthening social support, and promoting participation in daily routines. And like psychological intervention strategies include like solving approaches, cognitive behavioral approaches, behavior activation, and others. These interventions are embedded in the routine visits. So no separate therapy sessions. It demonstrated like pragmatic adaptation of MHGAP module. And if you see the slides, like medication uses high, and the type of treatment, 99 they receive the treatment. So next slide, please. For the functioning and outcome measures, if you see the charts, like overall days out of role, in the baseline, it was 2.8. In the first follow-up, it is 0.9. If we segregate that in depression, it was 3.3 in the baseline and 0.9 in the first follow-up. And for anxiety, it was 2.5, and then it was 0.8. If we see the WHO disability assessment schedule scores, it is 2 in baseline, 1.8 in the first follow-up, and 1.3 in second follow-up. So both WHO disability assessment schedule and the day out of role scores showed significant improvements across follow-up visits. So improvement was most pronounced among participants with anxiety and depression. Next slide, please. So what we learned, we found that there is a lack of availability of the key psychotropic medications, particularly those used to treat depression and anxiety. This gap indicates a need for policy follow-up to ensure that the appropriate medicines, especially SSRI and other recommended anti-anxiety medications, are fully included and accessible through the National Essential Medicine List. At the same time, we noticed that benzodiazepines were prescribed more frequently than recommended. This over-reliance on benzodiazepines may reflect limited availability of alternative first-line options like SSRIs. In response, the WHO team is now working closely with the government to expand access to safer and evidence-based medications by updating the essential medications list and improving the supply chain availability at the primary healthcare level. Next slide, please. So policy and programmatic implications, it's like, yeah, this kind of study is very important, and it can be scalable. It can be a scalable model for the national health information system. Currently, in our health information system, there is no mental health. There is no mental health indicators. So, and we learned that capacity building, MHF training for general physicians and nurses is showing tangible service delivery outcomes. Call for like refresher training and supervision is needed. Incorporating functioning measures like WHODS and days out of role as standard indicators can demonstrate social impact of primary healthcare integration, and establishing continuous feedback loops from Sentinel data to district to the national planners will improve the responsiveness of mental health policy. Next slide, please. So in the end, we can say that the findings from our study are highly encouraging. That demonstrate that the MHGAP implementations appears to be feasible, acceptable, and effective within the Bangladesh primary healthcare system. Data checks that this type of structured monitoring offers a practical, low-cost method for tracking both clinical and functional outcomes. We saw that almost every patient received comprehensive care, combining medication with essential psychosocial support. However, sustainability requires dedicated action. We must focus on the mental health indicators to include the national information system and for the long-term surveillance. And we need continuous capacity building, establishing feedback mechanism are vital to strengthen the entire system and improve the responsiveness of our mental health policy. Next slide, please. I should have said in the first, like in Bangladesh, we have Mental Health Act, Mental Health Policy, and Mental Health Strategy. In the last few years, we have achieved many things, and now we have to continue this process. So I want to thank you, everyone, and thank you, Dr. Allison. I think I am on time.
Yep.
So this is end of my presentation. Thank you.
Amazing. Bravo. Thank you so much, Lenildo and Ishakul. You can see in our special initiative countries, we're not hiding from the fact that that measurement is challenging, and the results in the real world, this was a naturalistic observational study of what was realistically happening in real time. So this was not a strategically set up randomized control trial. This was a study that was conducted, for want of the better word, in the wild. You know, this is what was really happening. And it's interesting to say that, you know, MHGAP is having a great influence and it's having some positive service user impacts. But at the same time, there's still a lot more work to be done in the data collection in a systematic, routine way. Back to what Dan was saying earlier, that we're still really lacking that everyday data information. This information that Lenildo and Ishakul has presented is not things that are routinely available in the digital systems at the country level. So, so this is something that we have to balance very carefully between implementation, research, and data. So I'm just gonna, we only have 1 or 2 minutes for questions at the moment. We're running a little over time. I wondered if there was anything pressing in the Q&A that we, on this topic, that anyone, Giovanni or Lydia, could you maybe jump in?
Yes, so there's a question, I think, for you, Ali.
Yep.
And that's, what were the criteria for selecting the 5 countries? And I imagine they're referring to the sentinel surveillance countries.
Yeah.
And then there's a question for Ishakul, asking who collects these data and how much additional time does it take? And then if we have the time, there's another question that's more general, and that's what are the lessons learned from implementation of MHGAP in low middle income countries? That's a big one for anybody who'd like to take a stab at it.
All right. So let me just say the answer to how we selected the 5 countries to participate. It was actually a self-selection. So countries opted in. So we offered the support to the studies for the service user outcomes to all 10 countries, or to all 9 countries at the time. Cambodia wasn't part of it, they've just joined. And 4 of the countries felt that they already had enough workload and it would be a bit difficult for them to do at that point in time. So the countries actually from the special initiative were self-selected. So that was pretty easy to decide on. I'll just quickly say that implementation learnings of MHGAP is a really big topic. But we are going to look at some of the cross-country results, and we are looking at in the next 6 months, maybe publishing a paper on that. So that will actually, we're going to start to try and draw out the learnings from individual countries and what might be some common learnings across the 5 countries that undertook this same method study. And we hope that that might also, in the scientific literature, contribute to some learnings about MHGAP. At the same time, we're also going to do a simple 2-pager to share with you the results from individual countries as well as what the cross-country results are. One of our 5 countries is actually still collecting data. So one of the learnings we have, I think, that's common across all the countries is the follow-up appointments are very hard to achieve. Many people don't attend follow-ups. So the data collection did take a bit longer than everybody initially thought. Yeah, just to let you know, this is something that we'll be publishing in various journals and on the Special Initiative website over the next 6 months. So keep an eye out. Ishakul, over to you for your question about the data collection.
Thank you, Dr. Allison. So what we did at first, we trained the MHGAP to the doctors and nurses in our district and Upajala health complexes. So those 3 facilities, the doctors and nurses are trained. When patient come to the doctors in the OPD, mostly, they identified which patient can be enrolled, then they diagnosed and give the treatment. So both doctor and nurses, they collected the data, but the data was entered in the system by the nurses.
Yeah.
And for the additional time, yeah, it took some additional few minutes, but not much. Like for complete data collection and entry, it took like 10 to 12 minutes approximately. In some cases, maybe 15 minutes, but approximately not much time.
And am I right, Lenildo and Ishakul, that the routine questions in follow-up visits happened faster? So the more people were asked the same questions in follow-up visits, there was economies of scale in time. Yeah.
Sim. Nós outros fizemos uma capacitação para os médicos da USF, né, sobre o instrumento. E também o que nos ajudou muitíssimo é que teníamos um psiquiatra que dava todo o suporte para esses 16 médicos da USF. Então, quando eles tinham alguma dúvida de algum caso, eles podiam recorrer, criamos um grupo de WhatsApp, uma comunicação, e isso um profissional ajudava o outro. E também nós outros, desde o nível central, junto com a gente do Ministério, hacíamos visita às USF nos 2 primeiros visitas para certificar de que estavam seguindo bem o protocolo, porque acá há muita complexidade em relação à participação dos pacientes. Então, para ter todo esse cuidado ético. E isso também resultou muito positivo, assim. E esse intercâmbio que teníamos entre os médicos e o psiquiatra que dava toda a retaguarda, que levou a gente a ter um bom resultado. E claro que isto também fortaleceu, e está fortalecendo, porque acá tem uma direção de saúde mental e tem uma direção de APS, né? E às vezes há uma dificuldade de comunicação. E lá a APS tinha dúvida, né? E como em qualquer país, se realmente MHGAP funcionava. E agora, com esse estudo, com essas evidências, isso vai fortalecer. Hoje, por exemplo, o Banco Mundial está financiando a implementação de MHGAP em mais 10 departamentos desse país, né? E claro que vamos também desenvolver outros estudos em outras regiões, né? Para a gente estar certificado de que realmente funciona e para a gente ter mais evidência. Pero para nós outros não há dúvida, para o Ministério de Saúde não há dúvida, para la APS e também não é dúvida com os resultados. Mas há que fazer esse segmento. E isso também ajudou a fortalecer o quê? Fortalecer a rede. Perdona que estou estendendo um pouco mais, mas que esse trabalho ajudou a fortalecer e a construir a rede de saúde mental que estamos fazendo no país. Câmbio.
Thank you, Anildo and Ishakul. We're really starting to see now how some of this data and information is actually informing the practice and the policy in each of the countries. So you can start to actually see that link where the data is providing information for better programs, better policies, better ongoing data information, and better practice for mental health services. But data actually also influences our funders and people who support mental health programs around the world. So I wanted to say a special thank you to Grand Challenges Canada, to Abigail for joining us from GCC, who is a positive supporter of a couple of countries in our special initiative for mental health. And Abigail's going to share us some perspectives on data and information from the donor perspective. Thank you, Abigail.
Thanks so much. It's a pleasure to be here. Hi, everyone. I'm going to start off by sharing a bit about who we are at Grand Challenges Canada and how we support mental health work. Could we go to the next slide, please? So Grand Challenges Canada is actually one of the world's largest impact first investors, and our mission is to build a healthier, more equitable world by supporting local, scalable innovation. We provide funding in two major ways. The first is that we provide proof of concept funding so that innovators can test their ideas through small short-term grants. And the second is that we build innovator capacity to transition their innovation to scale with flexible funding and bespoke technical support as well. And that's through our Transition to Scale program. Can we go to the next slide? Thank you. So GCC was launched back in 2011, and over the past 15 years, we've funded over 1,600 innovations, and the innovations that we've supported are in over 100 countries, and the majority of our investments are locally led by innovators in low and middle income countries. Okay. Can we move to the next slide? Thanks. So since the beginning, mental health has been an important part of Grand Challenges Canada's work, and we now steward funding in two key areas within this umbrella. The first is through the Being Initiative, which it focuses on the prevention and promotion of youth mental health. And the second is through the Global Mental Health Portfolio. And the Global Mental Health Portfolio has a broader focus than the Being Initiative, and it includes innovations focused on mental health treatment and access to care, as well as prevention and promotion. I'd like to take the opportunity also just to note that within our Global Mental Health Portfolio, we are partnered with the WHO Special Initiative on two exciting projects. The first is Live Life in Bangladesh and Ghana, and the second is the Friends Project in Zimbabwe. Can we go to the next slide? Thank you. So as a donor, there are a few reasons why data and impact measurement are especially important to Grand Challenges Canada. The first is that as an impact first investor, it's really important for us to know that the ideas that we are investing in have the highest potential to generate meaningful, lasting impact. And by that, I mean it's important for us to have some way of understanding that the innovations that we're funding are changing lives on the ground. And also, we believe that that building a rigorous evidence base is really necessary to set innovations up for success, so that after when the time comes for an innovation team to move on from our funding, that they are able to scale sustainably and also attract new partnerships as well. This is especially the case we found with newer innovations who may have less M&E experience. While impact is important to GCC, I'd like to note that our measurement expectations really depend on how far along an innovation is in its path to scale. So for example, there's no evidence requirements for applying for our proof of concept funding because really the purpose of these grants is to pilot and test an idea. Eligibility for our more mature funding, however, is informed by an evidence base and requires that innovators move along with us to expand the evidence that supports their work. Rigor is important to us, and in a lot of spaces, rigor is equated with the carrying out of a randomized control trial, but that's not the case at GCC. It's been our practice to avoid prescribing these types of studies because we understand in many spaces, including mental health, that these sorts of studies are not always pragmatic or ethical. And so what tends to be more common is that we support innovators where they're at and encourage or support the use of other studies, such as quasi-experimental studies or observational research methods as well. Historically, we've really been interested in supporting innovators to measure mental health outcomes that are more treatment or clinically focused, such as, reductions in symptom severity or improvements in functioning. And these are important, and our thinking is actually beginning to expand on this through the Being Initiative. We're very much focused in the Being Initiative on supporting innovators to measure meaningful changes in more upstream determinants of mental health and well-being for young people. For example, self-esteem, resilience, connectedness, emotional regulation, knowledge and attitudes. The list is quite long, and what's possible is quite expansive here. Okay, I'm ready to move to the next slide. Thanks. As a donor, I think it's important to just share that Grand Challenges Canada is really familiar with some of the challenges that innovations and mental health implementers face when it comes to measurement. And our expectation around measurements are shaped and informed by some of these challenges. I just want to take some time to acknowledge what some of these challenges are. The first is balancing the need for standard tools with contextual relevance. There's a lot of really great, commonly, widely understood measures out there, like the PHQ-9 or the GAD-7, just to name a few. However, we've learned through our work with innovators that these are not necessarily a one-stop solution, especially in the prevention and promotion space. There can be very practical challenges associated with using these tools. So for example, sometimes the concepts or the way that mental health is understood is very different in some of the contexts where we operate. In areas where there's lower levels of literacy, for example, it may not always be feasible to use a self-reporting tool. For many innovators we support, it can be really overwhelming to find the right tool. There's so many options in this space, and so we recognize that this can be a challenge. Also, just doing M&E can be hard, especially in low and middle income countries in areas that are under-resourced. And this is, of course, true for many of the mental health innovators we support. Doing data analysis can be challenging, especially if you're a new team learning how to do M&E work, or if you're using a mental health tool that may not have clear validated thresholds or cutoffs, for example. And finally, we acknowledge that it can be challenging because there are different stakeholders to engage, and all of us tend to have different data requirements, GCC included. So we do recognize that sometimes innovators have multiple data requirements on their shoulders. Okay, could we move on? Thanks. I just want to take a few moments to share how data informs our work at Grand Challenges Canada. For mental health, our funding calls are shaped by expert consultation and evidence. For the Being Initiative, for example, we conducted extensive landscape analyses in all of the 12 priority countries where the initiative is being funded. The landscape analysis involved a great deal of consultation with experts and young people, as well as desk research. Evidence is also a critical piece for determining future funding directions for us. So innovations funded at proof of concept that show promising signals of impact on mental health outcomes may be invited to apply for further funding in our transition to scale program. And within our transition to scale programs, it's very important that we support innovators to continue to grow their evidence base and that they begin to demonstrate that the innovation is impacting in some way mental health outcomes, or even proxy indicators for that matter. And as a function of this, every innovation that we support has progress reports and M&E data to submit to us regularly. We also look to data from our current and previous rounds of funding to help shape and refine our programs so that we're best positioned to support innovators as well, and even refine the way that we, for example, provide technical support. I think I'm over time, so I'll stop there, but thank you so much.
Thank you, Abigail. There's a clear message here that data is not just about getting grants, but it's actually about shaping the direction of future grants and future funders. And I would go so far as this isn't just about the funding from donors, but also potentially about funding from government into the local mental health systems as well. We are running over time, but I am so excited. We still have plenty of time for our final speaker, which is Maria Davina O'Brien. Maria, thank you so much for joining us. We really wanted to put the service user at the end of this session because we've been talking about data. We've been talking about service users and outcomes and quality of life and follow-up and numbers and percentages and all of that. You know, behind every single figure is a human being. It's a real person. Am I right, Maria?
Most definitely. And I'm so excited to be here today and so grateful for the opportunity to advocate for some of the findings that we have had doing our own research with the WHO Symposium for Meaningful Engagement Committee. So I'm going to dive right in. Thank you, everyone. So my name is Maria Davina O'Brien. I'm a social entrepreneur, mental health innovator, technology ally, and co-founder of MindWise Project, a mental health nonprofit focused on increasing accessibility to mental health information and resources here in the Caribbean and SIDS. I'm a breast cancer patient, a person living with PTSD, and a survivor of another suicide, a person struggling with depression, survivor of addiction, violence, trauma, and so many things that have become the front line in our fight to normalize mental health as a priority in our world. I also serve as a member of the WHO Symposium for Meaningful Engagement Steering Committee, where we have worked together to develop the key messages that you see on the screen right now. I will also link it in the chat. I also serve as the country lead for Intrepid 3, a research project on psychosis by King's College and University of the West Indies, where I work with a lived experience advisory board who supports and helps design this research. Through these roles, I have found myself experienced in both engagement of service users and, of course, being engaged as a service user, as I am in this moment, to gain insight into what's really happening in our public health and private health spaces. Sorry about that. It is often in emergency situations where needs are the greatest that many injustices and violations take place, which is why organizations like the Global Mental Health Action Network are advocating for the deinstitutionalization of mental health services to allow for community-based mental health care that is co-designed with the patient and honoring their humanity in their greatest moments of need. I will be talking about how data might not be collecting the full scope of measurement around mental health needs in our communities, and how service users or lived experience experts can play a major role in the improvement and validation of research, and how it shapes our health spaces and communities. I was asked today to reflect on how service users feel about the current status of mental health data, and perhaps we need to add to that the lack thereof. Here in the Caribbean, we suffer with a great lack of data. At a parliamentary inquiry several years ago, it was found that we could not state the specific prevalence of certain conditions in our mental health hospital, of which we only had one at a time, due to the problems with our archival system and processes for keeping records. The basic data collection and archival technology around the prevalence and patient records seems to be a fundamental issue, and I'm sure it's not just here in the Caribbean. Thanks to the work of many global and regional organizations, we do have data that gives us some indication of what is happening, such as the recent 2024 STEP survey. The STEP survey is a World Health Organization's stepwise approach to NCD factor surveillance, which allows for collecting and analyzing and disseminating data on key NCD risk factors in countries. There was also a recent regional survey into youth mental health in the Caribbean, delivered by UNICEF and CARICOM. However, outside of this and other academic and advocacy patient research, including the projects I'm currently involved in, how do we see mental health patient experience being measured and the outcomes being measured? Who in the supply chain of patient services is collecting the data around our unmet needs, such as recent crises such as grief or loss of employment, financial distress, suicidal ideation, self-harm, recent substance abuse, or negative coping mechanisms? So many things fly under the radar that are direct factors that affect our mental health. that could be so easily collected in our monthly intakes or clinic sessions. We need bold and experimental approaches to making what is unseen seen. Sometimes I do feel it is only in rooms like this, with other persons with lived experience of entities and mental health conditions, has the patient voice come first. So on behalf of all service users, might I be so bold, I would like to say that the data that is directly impacting our service design is not enough and needs to be more regular and expansive into the various factors that affect our treatment plans, our post-treatment plans, and the capacity of a patient to maintain those plans. Community mental health programs and access points, some of which we saw examples of earlier in this talk, it was really, really great, especially given the challenges of persons with mental health conditions, some of whom I work with directly, with basic mobility or the capacity to move far outside the community and sometimes even far outside the walls of their home is very important. We need to see more support outside the hospital in our communities. This is not just for the patients, but for the professionals delivering the services, who very often play a huge role in the experience of that service. I would like to raise a question around the population's familiarity with certain studies or surveys. Very often, fellow patients of mine have never heard of certain surveys that were being done, and that can feel like exclusion or negating their voice. Are the data points accessible to all? The digitization of the data collection processes also seems to be an urgent need that should be prioritized. So many of us who live with entities and mental health conditions regularly use apps and websites that help us manage and track our moods and symptoms. Working with apps like this might also be an opportunity that needs to be explored in making sure that surveys or data points are being promoted. Also, those who are in most urgent need, isolating and coping on their own, should have access to share their views and experience. What are the obviously ethical considerations related to collecting data around mental health? Ethically, I can say the value of the service user in research is not reflected. While patients are engaged in research, a very vital role for the success of service evolution, not much different from our patient experience as research subjects, there is not much consideration for our lives outside of your survey or tool. I have flown around the world to conferences with fellow lived experience speakers, some of whom return to their countries unable to afford their medications or support their families. I would like to refer to some of the points from our key messages. I went over time. I'm really sorry about that. Firstly, we need to ensure inclusive and equitable representation of people with lived experience across age groups, genders, and demographics. We must create safe and enabling inclusive environments for meaningful engagement, particularly for the underrepresented and most marginalized. We must provide accessible and transparent channels for communication and collaboration. How can data needs be addressed with service user engagement, and what might that look like? Show us the data. I think that the transparent sharing of collected data with the public, and of course lived experience community of that location, will reveal many things. And making sure that we have committees of service users who can give feedback on findings and ask relevant questions and give support tools and research plans. Formalize these structures and service user representation rules into your organizations, your ministries, and your strategic teams. That is what service user engagement or meaningful engagement, as we refer to it, looks like. I really do hope that everyone might be able to access the key messages linked here. And you'll see detailed in there the findings that was collected with thousands of contributions from persons with lived experience all over the world. Thank you so much for this opportunity. I definitely went a little over time, so I appreciate it very much, and looking forward to hearing more and hopefully contributing to the work being done with the Mental Health Initiative. Thank you, everyone.
Bravo. Thank you so much, Maria. It is so great to hear the passion, and I love some of the things that you've reflected on, and the importance of making the unseen seen. And that also means making the voiceless have a voice, and ensuring that our methods, our results, and our interpretations of all this data that we're talking about actually has service user engagement from the beginning, the middle, to the end. And certainly I want to say in our special initiative countries, we are in the process now of preparing some data summaries so that we can report back our findings to the people who participated in the research. So that is something that will be happening over the next coming months. I had really hoped we would have more time for questions. This is just such a hot topic, and I do wonder if maybe another learning session on this topic is warranted. We will record all of your questions. We go through the questions very carefully at the end, and for any questions that remain unanswered, we sometimes send an individual email and actually do respond to questions. So if you've put a question that we haven't been able to answer, we apologise, and we do hope that we will get to you individually to provide some responses and some thoughts into the questions that you've posted. So thank you. It's time we must wrap up. I think there's so many takeaways from here, but I do want to finish with that service user perspective. You know, data is about helping the unseen be seen, and that's why we need to collect more of it. It's why we need to do it in a consultative way. We need to be flexible in how we do it, and we need to strike that balance in ensuring that we don't limit data services to be able to have perfect data, but we need to still have great data, meaningful data with meaningful engagement of service users so that it feeds one to the other. Thank you so much to all of our speakers today. Thank you, Lydia and Giovanni, for being available as always. And a special shout out and thanks also to Joy from the Mental Health Innovation Network. MHIN is an important partner for WHO. We have a lot of engagement with them, and we love working with you, Joy, and MHIN team. So thank you, everybody, for participating today, for your questions and your insights, and we hope you can join one of our next learning webinars in the new year. Thank you.